is the after the after the sentinel lymph node biopsy. Specimen has been sent for the frozen section. If the frozen section shows nodal metastasis by any means, they underwent a neck dissection in the same sitting. If the frozen section is negative for any nodal metastasis, those patients will be undergoing sentinel lymph node biopsy alone. And if the final histopathology reported as any nodal reports any nodal metastasis, those patients underwent second look surgery within 6 weeks of first surgery. There is another group of patients included by the authors. They were not having any positive sentinel lymph nodes, but in them supraomohyoid neck dissection is done because the primary is resected through pull-through approach. So to prevent the shine-through effect, they prefer to excise the primary lesion wherever possible. Coming to the postoperative adjuvant treatment given in this study article. So here they ensured that those patients with extracapsular spread, they made sure that they receive radiotherapy within 6 weeks of surgery. Other concomitant chemotherapy was left at the discretion of each institution. And those with positive tumor margin, reoperation or radiotherapy with or without chemotherapy was performed according to the judgment of each institution. And this adjuvant treatment, in this article, they didn't mention much about this adjuvant treatment. Coming to the functional analysis, they did with the arm abduction test and with the neck disability quality of life questionnaire, which is performed at every 3 months, first month, third month, 6th month, and 12th month after neck dissection. So this was the questionnaire used for assessing the neck and shoulder function. So the it is graded into 1 to 5 scores. Score 1 is the worst score and 5 is considered as the best score. And the arm abduction score, the 5 is considered as up to 180° without pain or effort. And the 0 or 1 score, the score 1 is considered only they could raise they can abduct only around 90°. Coming to the follow-up, they followed up the patients every 6 monthly for a period of 36 months, and they specifically looked for local recurrence, cervical lymph node recurrence, and distant metastasis. Coming to the statistical analysis part, so to prove the non-inferiority of sentinel lymph node biopsy, they had to include at least 130 patients per group. So finally, they included 274 patients, considering a loss of 5%. The overall survival time, it is defined as duration between date of registration and death or last follow-up. And the disease-free survival time, it is defined as duration between date of registration and relapse, death, or last follow-up. So Kaplan-Meier survival curves are used to assess the survival rates. And the difference in the postoperative quality of life and arm abduction scores between the two groups is tested using Mann-Whitney U-test. And the p-value of less than 0.0125 is considered as statistically significant for quality of life and arm abduction score, abduction test. So coming to the result, so there were 275 patients participated in the study. They were randomly assigned into the neck dissection group and the sentinel lymph node biopsy group. So of the 275 patients, 4 patients were excluded from the study from the beginning itself. And among the 271 patients, 137 patients considered in the neck dissection arm and 134 patients in the sentinel lymph node biopsy arm. So this is the flow chart given in the article. Here it is run patients 271 initially considered 275 patients. So for the final analysis, they considered 271 patients. So in the neck dissection arm, 137 patients, and in the sentinel lymph node biopsy arm, 134 patients. So here we can see in the neck dissection arm, those patients, only 133 patients had underwent the elective neck dissection. 4 patients did not undergo any treatment. And in the sentinel lymph node biopsy arm, there was an intraoperative frozen section. So 132 patients underwent intraoperative frozen section, and all of that, there were 45 sentinel lymph nodes were positive, and overall 45 patients in the sentinel lymph node biopsy arm underwent neck dissection. And there is another group, as I mentioned already, those resected via pull-through approach with a negative sentinel lymph node and subsequently underwent elective neck dissection with a negative sentinel lymph node, 8 numbers. So the neck dissection rate in the neck dissection group is around 97%. That is 133 out of 137. And in the sentinel lymph node biopsy, it is 39.5%, 53 out of 134. So coming to the characteristic of patients. So here we can see this is the elective neck dissection arm, and this is the sentinel lymph node biopsy arm. The median age considered in both groups is 63 years, and the male population was the predominant population in both the groups. In the primary tumor, majority were the primary lesions were on the tongue in both the groups, and so that means the both groups were comparable. And coming to the T category, most of the lesions were coming under T2 category. In the surgical approach, they did a transoral as well as pull-through resection. So both numbers were comparable in the both the groups. It's a more like homogeneous population they considered for the randomized control trial. So coming to the neck dissection. So in the elective neck dissection arm, 4 patients did not undergo any neck dissection. So 128 patients underwent unilateral neck dissection, and 5 patients, those tumors reaching the midline and crossing the midline, underwent bilateral neck dissection. In the sentinel lymph node biopsy group, 48 patients underwent unilateral neck dissection, and 5 patients underwent bilateral neck dissection. So out of the 48 underwent neck dissection, 7 patients were underwent neck dissection because of the part of pull-through resection. So here, we next coming to the pathological nodal status. So elective neck dissection arm, 72% of the patients were pathologically not negative in the final histopathology report, and only 34 patients were positive for nodal metastasis. And in the sentinel lymph node biopsy arm, 46 patients were found to have nodal positivity. Coming to the postoperative therapy, here the majority of the population in both the groups did not undergo any adjuvant treatment. Here we, in spite of nodal significant number of nodal positivity mentioned in the above chart, the here on in the elective neck dissection arm, only 3 patients underwent adjuvant treatment, and in the sentinel lymph node biopsy group, only 4 patients underwent adjuvant treatment. Coming to the metastatic status in the sentinel lymph node. So pathologic positive nodal status is confirmed in 24.8% in the neck dissection arm and 34% in the sentinel lymph node biopsy arm. That is, it is found to be not statistically different in both groups. So coming to the metastatic status of sentinel lymph node, so they could identify in the frozen section, 32 positive cases were identified, and the final HPR, 45 patients were identified. So the sensitivity of frozen section was found to be 68.5%. And the sentinel lymph node detection rate is 98.5%. That is 132 out of 134 patients. And an average of 3.2 sentinel nodes were identified per patient. Coming to the overall survival and disease-free survival. they did a median follow. Their median follow-up period was 3.1 years. So among the 271 patients, 33 patients were censored from the follow-up, and 3-year overall survival in the sentinel lymph node biopsy group is 87.9 percentage. That means it is a sentinel lymph node biopsy is found to be non-inferior to that of the standard treatment neck dissection arm in overall survival, and the disease-free survival in the sentinel lymph node biopsy arm is 78.7 percentage. The disease-free survival at the end of 3 years, it is found to be non-inferior to that of neck dissection. Functional analysis, then it is found that the neck stiffness was worst at the first month, and it was improved over the time. And the other functional scores like constriction, pain, shoulder drop, reach above, neck appearance, everything were showed a similar trend. And the result of quality of life and arm abduction test were found to be significantly better in the sentinel lymph node biopsy arm. Coming to the pattern of recurrence of the total node positive cases, the neck dissection arm, the 18% of the patient in the neck dissection arm had a local or regional recurrence, and also in the sentinel lymph node biopsy arm, around 21 patients had a local or regional recurrence. There is no between group differences noted in the distribution. Here we can see this is the elective neck dissection arm. This one is the sentinel lymph node biopsy arm. 4 patients got a regional recurrence. They were actually pathologically, the final pathological examination reported as node negative, and of which 4 patients had a regional recurrence at the end of 3 years. And in the sentinel lymph node biopsy arm, 7 patients with the negative sentinel lymph node had a recurrence. So the false negative rate in the neck dissection arm is 10.5%, and sentinel lymph node biopsy group, it is 15%. False negative is considered as the recurrence occurred after a pathologically or negative node. Coming to the adverse event, there is reported to be 20 patients out of 137 had a adverse event in the neck dissection group, and sentinel lymph node biopsy group had 12 patients had a adverse event. So this is the post-operative complications chart. It is categorized based on the CTCAE score. So here we could see one patient in both the group had a grade 5 morbidity, and other number of the patient who had postoperative complications were comparable, and it was not statistically different in both the groups. Coming to the discussion, so as mentioned by the author, so positive of the study, they could do a single stage neck dissection along with a sentinel lymph node biopsy in those cases with frozen section reported as sentinel lymph node. So the positive about the study, what we found is it's a randomized controlled trial with a significant number of patients, and it's a multi-centric trial, and they considered a significant homogeneous patient population. The limitations, as the author mentioned, they considered a non-inferiority margin of 12%. So a smaller margin might have been a better for proving a non-inferiority of sentinel lymph node compared to the neck dissection group. And the limitation what we found is few patients, they did not undergo any procedure is considered in the analysis. Also, we know that the sentinel lymph node biopsy arm, if the sentinel lymph node is positive, these patients are undergoing therapeutic dissections of level 1 to 4 or level 1 to 5 clearance, either in the single as a single procedure or in the second look surgery. But in the neck dissection arm, patients undergoing only supraomoid neck dissection in spite of nodal positivity in the final HPR. So number of positive nodes also they did not mention in their article. And also here we can see they mentioned a significant number of positive nodes, and but the patients who received the adjuvant treatment is significantly lesser number. It is actually contradictory to the current management protocol. So the few points I wanted to add is the sentinel lymph node biopsy. It is actually an operator dependent procedure with an expected learning curves. So if for implementing sentinel lymph node biopsy in smaller centers and all, it will be a little risk a difficult task. And sentinel lymph node biopsy, it will be really useful in recurrent as well as treated cases, because in these cases, there will be an chance for aberrant lymphatic pattern. So we can utilize the sentinel lymph node biopsy in these cases for identifying the sentinel nodes and aberrant lymphatic pattern, and subsequent clearance of these levels can be done. And most of the sentinel lymph node trials have excluded these cases for in their studies. And also those patients undergoing sentinel lymph node biopsy and with a node negative, with coming as node negative, they are kept under follow-up. So the complaints for the follow-up has have to be considered, because clinical as well as radiological compliance is clinical and radiological examination is required in these patients for in case of to pick up early recurrence in the regional or local regional to for considering for a salvage procedure. And the ideal lesions for a sentinel lymph node biopsy is basically those lesions that can be resected with clear margins without requiring a neck access. So to conclude, the sentinel lymph node biopsy navigated neck dissection is found to be non-inferior and less invasive than elective neck dissections. So this is a landmark trial. Um, uh, This is a landmark trial published in 2015. Dick Cruz et al. Published in NEGM. This is a prospective randomized controlled trial. Based on this, this study showed a benefit of elective neck dissection over a watchful waiting, followed by a therapeutic neck dissection for nodal relapse in early stage clinically node negative oral squamous cell carcinoma. This showed a absolute overall survival benefit of 12.5% and disease-free survival benefit of 23.6%. And based on this article, the current standard of treatment in a node-negative neck is elective neck dissection. And the minimum nodal clearance in a node-negative oral cavity squamous cell carcinoma is at least level 1 to 4 has to be cleared, considering the chance for the occult nodal metastasis as mentioned in the Pant Vaidya et al. So this is an early article on sentinel lymph node biopsy published in Journal of Clinical Oncology in the year 2010. Sivandos et al. This was a prospective cooperative group trial, included 140 patients. So they found a negative predictive value of 96% for the sentinel lymph node biopsy with step sectioning and immunohistochemistry. So this can be applied for sentinel lymph node biopsy trials. So this is another study where it is showing the long-term follow-up and nodal failure analysis in early oral cavity squamous cell carcinomas, published in 2018 in Oral Oncology. This was a Moya Plana et al. This is a single center prospective cohort study. They included 229 patients. So there were two arms, one group sentinel lymph node biopsy followed by systematic neck dissection. Another one is sentinel lymph node biopsy followed by selective neck dissection. So here they studied the overall survival and recurrence-free time. So this arm is the sentinel node biopsy cohort, and another is the systematic neck dissection cohort. So overall survival as well as recurrence-free time is found to be not statistically significant difference was found between these groups. So it is indicating that sentinel lymph node biopsy did not adversely affect the oncological patient survival outcome. This is a French study, senti-mirroral trial by Garel and his colleagues. This is an equivalence trial. They included a total of 307 patients, primarily studied the neck recurrence-free neck node recurrence-free survival. So, coming to their result, they studied the neck node recurrence-free survival, loco-regional recurrence-free survival, disease-specific survival, and overall survival at the end of 2 years and 5 years. Here we could see the sentinel lymph node biopsy arm at the end of 2 year and 5 year has a comparable result that of neck dissection arm, and in all the aspects. So there is no significant difference was observed between the arms regarding the neck node recurrence-free survival, loco-regional recurrence-free survival, disease-specific survival, and overall survival. Compared to our study, 3-year overall survival is found to be around 87.9% in the sentinel lymph node biopsy arm. So this senti-mirroral trial, which demonstrated oncological equivalence of sentinel node to that of reference strategy neck dissection, they also showed a same rate of neck failure, approximately 10% in the both the arms. This is SEN trial, Sentinel European Node trial, published in 2015 in European Journal of Cancer. They they recruited 14 European centers for 15 patients of T1, T2, N0 oral cavity cancers. They underwent a sentinel lymph node biopsy followed by therapeutic neck dissection in positive sentinel node cases versus observation with a median follow-up period of 52 months. This was funded by EORTC, and they identified sentinel lymph node in 99.5% of the cases. So here they derived a conclusion like they could, in 70% of the patient with T1, T2 oral cancer staged by sentinel node biopsy were able to avoid a neck dissection with an excellent 3-year disease-free survival of 92%. And their false negative rate is around 14%. In our study, sentinel lymph node biopsy had showed a 15% of false negative result. So, and one other remark in this article was those patients who underwent therapeutic neck dissection following the identification of sentinel lymph node, of which 22 had a recurrence in the regional recurrence. The majority 22 had a recurrence of disease, and majority got a regional recurrence in the already operated neck. So sentinel lymph node biopsy patient, 15% of the patient had a recurrence in the neck after 3 years. Those SLNB positive cases means they subsequently underwent therapeutic neck dissection. So this chart is taken from a critical review paper by, from the Tata. So here they critically analyzed Schilling et al., that's the SEN trial, Hasegawa and Garel et al. So the false negative rate in the Schilling and Hasegawa were comparable, and they also studied micrometastasis isolated tumor cells, and the Schilling they found a better rate of micrometastasis and isolated tumor cells compared to that of Hasegawa. So adjuvant therapy in the Schilling, 27% of the sentinel node positive cases received adjuvant treatment. In Hasegawa, only 3% received the adjuvant treatment. So overall survival, in Schilling et al., they mentioned 88.6% in the sentinel node biopsy arm for the overall survival at the end of 3 years. In the Hasegawa, 87.9% had a 87.9% was the overall survival. So this is an article for comparing the morbidity in the sentinel node versus elective neck dissection. This is published by Murer and colleague in the year 2010. This was a prospective observation study. They included only a number of 62 patients. And what they found is postoperative shoulder function was better in the sentinel node arm compared to that of the elective neck dissection. The score were almost normal. This is another study showing published in 2018 in Laryngoscope, which is showing again sentinel lymph node versus elective neck dissection. This was a retrospective cohort study based on National Cancer Database. And for them, the 3-year overall survival is found in the sentinel arm found to be 82%. And they also found that there is a reduced length of hospital stay with an improved shoulder function in the sentinel lymph node biopsy arm. Thank you.
Dr. Sandeep, would you like to make some comments?
A journal club. At the very onset, actually, there is a disclaimer that we are not an institution that is currently following sentinel node biopsy for N0 oral cancer patients, but we are in the process of acquiring it in the near future. So we are not actually the experts to say much about it. But what the information that we have gathered is from various articles. We have attended conferences where the experts have spoken about it, and then we have seen videos regarding the same. So when what I would like to say is that when we discuss a topic like this, what we wanted to do was touch upon various areas and discuss a journal along with it. So we selected this article because it was recent. It was a randomized control trial. There was another Garrel article which could have been taken, but in them the population was a little bit heterogeneous. They included oropharyngeal cancers also. So we thought we'll focus more on oral cancers only. So the questions at the while starting this discussion were first of all whether neck dissection is required, and if at all it's required, what all levels to be addressed. Then is sentinel node biopsy modality adequate enough? Is it sensitive enough? And then will it provide morbidity-free survival, recurrence-free survival, etc. And then I think Indu has been able to cover most of the points. And then a few points where we didn't actually focus now itself because we didn't want to make it too dilute. One point maybe Indu could explain is what is this shine through? You spoke about a shine through phenomena.
Yes,
and then, yeah, can you please tell us what is a shine through phenomenon? You said something about it.
Shine through effect is the radioactivity in the primary lesion. It can obscure the positive sentinel lymph node. It can obscure the positive sentinel lymph node if it is lying in the close proximity. So basically, this is applicable for floor of mouth lesions where the nodal basin will be in close proximity to the primary lesion. So the radioactivity in the first primary lesion, it can obscure the sentinel lymph nodes, and it can subsequently result in false negative or negative sentinel node metastatic report.
Okay, then another area which there is fairly discussion about with is regarding micrometastasis and isolated tumor cells. Actually, since there is a lot of ambiguity, that's why we didn't focus too much on it. Indu, can you tell us something about what is micrometastasis and isolated tumor cells?
So micrometastasis means a metastasis of like 0.2 to 2 metastasis that could see in the finer sections only, micrometer sections, and isolated tumor cells that will be of size less than 0.2 millimeters or less than 200 cells can be seen in the metastasis lymph node.
Basically, what the nodal positivity that we talk about on light microscopy is macrometastasis. This is something much more smaller than that, and even isolated tumor cells are even maybe a precursor to the micrometastasis. So why we didn't focus too much on that is basically because we are living in an era where many institutes do not give adjuvant therapy for even N1 diseases. So these are much more earlier to that. But in our institute, we do give adjuvant therapy for all N plus cases, even N1 cases. But here we have seen that in the Hasegawa group, many cases were not given adjuvant therapy. The reasons are not specified. They haven't even specified regarding the number of nodes that were found to be positive.
Dr. Sandeep, there is a question in chat box.
Yes, sir.
What is second look surgery?
Yes, sir. Indu, can you explain what do you mean by second? You had it in your flow chart. Second look surgery.
So here, what they mentioned by second look surgery is if the sentinel lymph node, all the sentinel lymph nodes which has extracted during the surgery has been sent for a intraoperative frozen section. So if the frozen section is reporting us node positive for any isolated tumor cell micrometastasis or macrometastasis, only in that cases they did a therapeutic neck dissection in the single stage. So other cases, because after the session, after the frozen section, these specimens are sent for a final HND staining, and in that staining they took a more finer sections, and if in that finer sections if they could find a metastasis positive metastatic foci in the nodes, so those positive cases they did not undergo any surgery therapeutic neck dissection in the first setting. They underwent a therapeutic neck dissection in the later, that is only in the sentinel lymph node biopsy arm. And here they said the second look surgery they did within the 6 weeks of first surgery.
So second look is actually if the uh, sentinel node comes negative
Yes,
but reported to be positive
in the
on
fine.
peripheral section,
Yes, sir.
but reported to be positive on section, then you do the surgery. That is second look surgery.
Yes, sir. But they have only gone for the second look surgery within 6 weeks. I don't know why there is such a big delay. Yes, sir.
Within 6 weeks, yes.
That seems to be too
One
much.
limitation of the trial, and nowhere it is mentioned, that extracapsular ENE, if it is present, then radiation was given, but chemotherapy option was left to the institute.
Yes, sir.
Yes.
Because nowadays the state of the art is chemoradiation for ENE positive.
Yes, sir.
This probably could be labeled as one of the limitations of
Yes, sir.
that
They have
field.
not followed the standard of care with
Yes,
respect to ENE. Yes, sir. Some
yes.
institutes have not given adjuvant chemoradiation for cases of extranodal extension.
In one of the tables, you have said pull through supraomohyoid neck dissection. Could you explain on this pull through supraomohyoid neck dissection? You have written if sentinel node biopsy is positive, you will do a neck dissection, and if it is negative, you are leaving it. Then the third column you have said pull through supraomohyoid neck dissection. So what is this pull through?
Sir, in cases of tongue carcinomas, here they consider T2 lesions only. So the approach is transcervical approach for the dissecting the tongue lesions. So there they are resecting the compartment along with the um, subs, adjacent nodal basis.
No. Suppose supraomohyoid, your this thing sentinel node comes negative.
Sir.
What will you do about the neck dissection? It was CA tongue. You will do a complete neck dissection or supraomohyoid neck dissection or just do a sentinel node. What will you do? CA tongue, you are operating T2 lesion.
Sir, ideally, tongue has got a more chance for occult nodal metastasis. So it is better to
We are
consider.
talking of the trial, this trial.
Yes, sir.
So
Okay.
what
But
have they
actually,
done?
in this trial, they have included some patients in which the lesions couldn't be excised perorally. We feel that those patients shouldn't have been taken. What they have done is, if they couldn't excise it perorally, they have gone for this pull-through technique. And then, if pull-through has been done, they have gone for neck dissection. Maybe those patients could have been excluded from the trial. That's what
Yes,
we feel.
yes. Because there's no mention of the report of sentinel node. They have only made a third column,
Yes.
uh,
Yes.
pull through supraomohyoid neck dissection. This is quite paradoxical.
Yeah. Yes, sir.
Any questions from the students?
So, adapting
Chat box
this
is
into
empty.
our setting is also a problem, sir. The cost and all that is also something which we haven't gone through. In the trial also they haven't discussed as much. In our
Yes, here is a question. Role of single dye versus dual dye technique in head and neck sentinel node.
It is better to take radio tracer along with indocyanine green, because it can this indocyanine green under white light it cannot be seen in the at the primary tumor site. It can be seen with a near infrared camera in the nodal basin. So if indocyanine green can be combined with a radiocolloid like technetium, so that will be the dual dye technique will be more ideal to avoid the shine through effect.
No, for
Most of the
breast it
center,
is
most of
done,
the
but for
centers,
head and neck, is there any trial saying this?
mm, I'm not sure.
No, sir, I don't think it's been objectively evaluated so far, sir. Single dye versus. We'll go through it again. Yeah.
Yes.
There is one more question. As per RTOG, EORTC trial, ECE positivity adjuvant chemoradiation confers better survival. That I think we have answered.
Yes, sir.
Yes.
That is the limitation of this study. Any other question? One final comment from Dr. Sandeep.
Sir, finally, at the end of discussing this article, as well as what we have understood by reviewing the literature, is that sentinel node biopsy, as Indu has also spoken, is that it can be taken into our setting also. What it provides is a better morbidity-free survival. Seems to be a better shoulder mobility after doing sentinel node biopsy as compared to elective neck dissection, better quality of life. But then the problem is lies there are many challenges, because in our setting the patients have to pay from there is no uh, insurance available for all patients, so they have to pay from their hand. Ultimately it seems as if you go for a sentinel node biopsy, the cost will be much higher. So there are various challenges to be encountered. What we would suggest is to use sentinel node biopsy in probably cases where the lymphatic drainage pattern has been altered, maybe in cases of recurrence, where it can be used, because then maybe even lateralized lesions can throw contralateral nodal mets, or even node mets to the level 5, where in the primary case it would be much less.
There is a very good question. Does tongue or floor of mouth needs bilateral neck dissection even in N0?
As of now, with the evidence that we have, all cases of tongue and floor of mouth do not warrant a bilateral neck dissection. That is what the objective evidence so far has suggested. But then there are studies
We are
showing
talking
that
about
lesions.
T1, T2 lesions.
Yes, sir. But lesions approaching the midline, crossing the midline do have a higher percentage, especially those crossing the midline do have a higher percentage of contralateral nodal metastasis. So that is a practice that we do follow. Lesions that tongue, floor of mouth lesions that do cross the midline, we do contralateral neck dissection also. Not for all cases of tongue
Would
and
you
floor.
like to sum up the indications of sentinel node biopsy in early oral cancer? What is the message you want to convey to the
So
Hindu?
Yes, sir.
Would you like to summarize the indications of sentinel node biopsy in early oral cancer?
Um,
The
yes.
last question for you.
Yes, so sentinel lymph node biopsy, it is considered as a personalized oncological treatment. So those patients, first indication, I feel like those patients wanted to do a lesser morbid surgery, wanted to undergo a lesser morbid dissection, can go for a sentinel lymph node biopsy. And other lesions, those reaching the midline or crossing the midline, even the T1, T2 lesion present at the midline or just reaching the midline or crossing the midline, if we could do a sentinel lymph node, if we can find any lymphatic mets in the contralateral side, so that can be addressed eventually if required basis. And another one is we can apply this in even in treated cases, like already those patients underwent radiation or already underwent
I think
treatment.
these
And
patients have been excluded from your study.
Yes, sir. This study has excluded, but the
So what are the indications of sentinel node biopsy in taking a clue from this paper?
so the recurrent cases and those treated cases, treated phases without any distant metastasis can be considered for sentinel node biopsy. So we could identify the exact apparent
T1,
lymphatic
T2 lesions, T1, T2 lesions of oral cavity. I don't know the CA tongue and floor of mouth which behave aggressively. Uh, should we be including for sentinel node biopsy or not is a big question mark.
Yes, sir. Advanced tumors are would probably we would not take them. Early lesions only as of now.
But oral cancer T1, T2, you can take up these patients for sentinel node biopsy. So this is one dimension which has been added to one of the options of treatment of N0 neck. N0 neck, we have been taught observation versus supraomohyoid neck dissection versus prophylactic radiation. So this is another dimension which has been added. You can do a sentinel node biopsy, navigated surgery uh, to reduce the morbidity while maintaining the oncological outcome same as supraomohyoid neck dissection. Am I right?
Yes.
Okay. So if there are no more questions, Navneet ji, can we call it a day?
Yes, sir.